The McEwan triangle, also called suprameatal triangle or mustard fossa, is a surgical landmark on the surface of temporal bone just superior to the external auditory canal. This is used for location of the mastoidectomy. There are three boundaries of this triangle. Superiorly, inferior temporal line or supramastoid crest extending back from the posterior root of the zygomatic process to the isthmus temporal bone. Anteroinferiorly, tangent extending from the posterior superior border of the external auditory meatus, including the suprameatal spine of the Henle, and posteriorly, vertical tangent extending up to the posterior border of the external auditory canal. So these three lines define the McEwan's triangle. The spine of Henle or suprameatal spine or spina suprameatica is a guide to the lateral wall of the mastoidectomy. It is located posteriorly on the lateral aspect of the external auditory canal. So this spine guides the mastoidectomy. The triangle of attack is the starting point of the cortical mastoidectomy. There are three lines. First line is the suprameatal line, that is upper limit of the external auditory canal extending from zygomatic bone to the sigmoid sinus. Second line, which drill parallel to the posterior to the external auditory canal. And third line connect the first two lines, and you can start drill between these three lines. So this is called triangle of attack. The cibriform area in the McEwan's triangle is perforated by numerous small holes that serve as passage for the vessel for the mucosa of the antrum. You can see there are multiple holes in the cibriform area just behind the spine of Henle. That also suggests the position of the antrum. Facial bridge is the portion of posterior superior bony meatal wall that bridges over the notch of Venus and overlies the ossicle, and this covers the part of the facial nerve from first genu to the second genu. So this is the part of the posterior meatal wall which cover the notch of Venus and tympanic portion of the facial canal. The notch of Venus is a small defect in the posterior edge of bony annular tympanic ring. The defect is located just superior to the tympanomastoid suture line in the posterior ear meatal canal. This bone, where this notch of Venus is present, above this bone is called the facial bridge. Buttress. Buttress means support. Anterior buttress is the point at which the posterior bony canal wall meet the tegment. Is called the anterior buttress. Posterior buttress is the point of which posterior canal wall meet with the floor of the external auditory canal just lateral to the facial canal. So posterior buttress is the support between the posterior canal wall and the facial nerve with the floor of the external auditory canal. After removing the facial bridge, the remaining part you can see that is the anterior buttress, and remaining posterior part which is near to the facial nerve is the posterior buttress. Facial ridge is the part of the bony meatal wall which houses the posterior band, means second genu, and vertical segment of the facial nerve. So bony portion that cover the facial nerve from the second genu to the stylomastoid foramen is called the facial ridge. Sinudural angle or stellage angle is angle between the sigmoid sinus and middle fossa dural plate. Actually this angle is between the sigmoid sinus and superior petrosal sinus. So actual angle is between the superior petrosal sinus and sigmoid sinus. It is the meeting point. That angle considered as a stellage angle or sinudural angle. Significance of this triangle, it defines the boundary of the vascular elements like superiorly superior pituitary sinus and inferiorly sigmoid sinus. These are the vascular elements. So this prevents the injury of these two elements. Trotman's triangle is bounded superiorly by superior pituitary sinus, posteriorly by sigmoid sinus, and anteriorly by the bony labyrinthine. It serves as surgical pathway to the posterior fossa from the mastoid cavity. Significance of this triangle is one is any infection in mastoid cavity can spread to the posterior cranial fossa through this route. Another, you can approach the posterior fossa lesion through this transmastoid approach or trans-Trotman triangle approach of the posterior cranial fossa lesions. Anterior boundary of this is the solid angle. What is solid angle? Solid angle is the meeting point of all three semicircular canal of the bony labyrinthine. That is called solid angle. Parietal notch or Bremer's pointer is a reliable surgical landmark to identify the position of sigmoid sinus at the sinodural angle. Parietal notch is a surface landmark on the posterior superior aspect of the mastoid process of the temporal bone and is defined as the point where the squamous suture lines meet with the parietal suture line. It is located anterior to the asterion, the point on the lateral skull base where the lamboid, occipitomastoid and parietomastoid sutures meet. The asterion is sometimes used by neurosurgeon during retrosigmoid craniotomy to help identify upper hole site posterior to the sigmoid sinus and inferior to the lateral sinus. In about 45% of cases, there is distinct cell type present that is called Herald cell. This cell is the gateway to the posterior tympanotomy. Posterior tympanotomy is the avenue of facial recess of the middle ear from mastoid antrum. The entry into the facial recesses many times is heralded by the distinct ear cell before approaching the facial caudal plane. This cell is known as Herald cell. Posterior tympanotomy or facial recess or Bulstein window is bounded by the facial nerve posteromedially, cauda tympani anterolaterally, and incus buttress or fossa incudis superiorly. You can see in this picture. This posterior tympanotomy mainly carried out in intact canal wall cholesteatoma surgery, cochlear implantation, and active middle ear device implantation. The facial recess is defined by the line drawn through the body of the incus across the posterior bony canal wall and posteriorly the facial canal wall, anteriorly being the caudal canal wall or cauda tympani. The landmark may be horizontal semicircular canal, short process of incus, tympanic segment of facial nerve, mastoid segment of facial nerve, cauda tympani, incus buttress, posterior tympanotomy ear cell tract that is Herald cells and caudal crest. These are the landmark to assess the facial recess. Digastric ridge is a bony elevation present inferiorly in the mastoid cavity at the level of mastoid process. The digastric ridge corresponds externally to the digastric groove at the medial aspect of the mastoid process, from which the posterior belly of digastric muscle originates. The digastric ridge divides the mastoid tip cells into two groups, lateral and medial group. Clinically, the digastric ridge is an important landmark in identification of the facial nerve and sigmoid sinus. The morphology of digastric ridge varies from person to person and usually more prominent in pneumatized mastoid than the sclerosed mastoid. This digastric ridge extends from sigmoid sinus posteriorly to the posterior meatal wall anteriorly. Average length of this digastric ridge is about 1.7 centimeter. The entry end of the digastric ridge is one of the landmarks to identify the vertical part of the facial nerve. The mastoid segment of facial nerve lies anteromedial to the anterior end of the digastric ridge at varying depth. Depth about 4.5 mm in the pneumatized mastoid and 3 mm in the sclerosed mastoid. So importance of digestive ridge. First is digestive ridge is important landmark to identify the vertical segment of facial nerve during mastoid surgery or transmastoid approaches to the middle or posterior cranial fossa. Second, facial nerve always lies medial to the anterior end of the digestive ridge, and length of the digestive ridge and distance of facial nerve from anterior end of digestive ridge are more than more in the pneumatized mastoid than the sclerosed mastoid, and it's also provide safer surgical corridor to prevent injury of the facial nerve or sigmoid sinus. The mastoid process is a smooth conical projection of bone located at the base of the mastoid area of the temporal bone. It allows the attachment of muscles such as occipitofrontalis muscle as well as certain muscle of the neck like sternocleidomastoid muscle, splenius capitis muscle, longissimus capitis muscle, and the digastric muscle. Inferior surface of the mastoid process having digastric fossa or mastoid notch, a groove located on medial side of the mastoid process, which is corresponding to the digastric ridge in the mastoid tip during mastoidectomy. This notch having insertion of the posterior valley of the digastric, which is most medial muscle of the mastoid tip. Another groove is the occipital groove, a furrow located medial to the digastric fossa or mastoid notch, that having the occipital artery that is arises from the external carotid system and mastoid ear cells. These ear cells are superior, inferior, and anterior area of the mastoid process. They are larger and more irregular cells, so these cells are located in the mastoid process itself. The rough outer surface of mastoid process also allows the attachment of occipitofrontalis muscle, and this muscle wraps the skull from superior nuchal line to the mastoid process. So most superficial and lateral surface muscle of the mastoid process is the occipitofrontalis muscle, or you can say occipital part of the occipitofrontalis muscle. At inferior surface, the mastoid process having attachment from lateral to medial. First muscle to insert on mastoid tip is sternocleidomastoid muscle. Then posteromedial to sternocleidomastoid is the splenius capitis muscle. Then posteromedial to this muscle is the longissimus capitis muscle, and most medial muscle in the mastoid tip is the digastric muscle, means posterior valley of digastric muscles. The mastoid ear cells present in the mastoid process also serve their own function like protection of temporal bone and middle ear inner ear, protection from the trauma, and regulation of air pressure. They communicate with the middle ear through the mastoid antrum and the editus and the antrum. So this mastoid process is very important for the middle ear function. Coda tympani arises from 5 mm above the stylomastoid foramen, and its passage medial to the tympanic membrane and medial to the handle of malleus, and it exists from the canal of Hoogier or Sibinini canal, and west is it is called anterior canaliculus. Posterior exit is called posterior canaliculus, and anterior exit of this chorda tympani is known as the anterior canaliculus. Another name of anterior canaliculus is the canal of Hoogier or Sibinini canal. After passing this anterior canaliculus, it goes into the petrotympanic fissure, and it ultimately joins the lingual nerve in the infratemporal fossa. Tympanic canaliculus is situated between the carotid canal and jugular foramen. It is minute canal which is situated medial to the stylomastoid foramen, and where the tympanic branch of the Glossopharyngeal nerve arises and it goes into the middle ear cavity through this tympanic canaliculus. Tympanic nerve arises from the inferior ganglia of the glossopharyngeal nerve, traversing through the tympanic canaliculus into the middle ear. On the promontory, it coalesces with the sympathetic fiber from the carotid chain, forming the tympanic plexus. Functionally, it provides somatic fiber of the middle ear as well as parasympathetic fiber of the parotid gland via the lesser petrosal nerve. The lesser petrosal nerve originates at the region of geniculate ganglia and carries mainly preganglionic parasympathetic fibers from tympanic plexus to the parotid gland. Although it is largest source of these fibers are coming from tympanic branch of the ninth nerve, the lesser petrosal nerve is actually result of composition of fiber contributed by three different nerves. First, main coming from the tympanic branch of the ninth nerve, and the nervous intermediate part of the seventh nerve, and auricular branch of the 10th nerve. So it is contribution of three nerve form the lesser petrosal nerve near the geniculate ganglia of the facial nerve. After exiting from middle ear, some fiber are coming from the meningeal branch of the mandibular nerve V3. So this lesser petrosal nerve is the combination of four nerve: tympanic branch of the glossopharyngeal nerve, nervous intermediate branch of seventh nerve, auricular branch of the 10th nerve, and meningeal branch of mandibular nerve. The lesser petrosal nerve leaves the middle ear, enters the middle cranial fossa through a small opening on the anterior surface of the petrous part of temporal bone. That canal is called the canaliculus innominatus, and it is just lateral and inferior to the opening of the GSPN. A part of LPN is often covered on the floor of the middle cranial fossa, about 70% of the cases, but can also be totally covered by the thin bone, about 25% of the cases. And its course along the middle cranial fossa, the LPN is located above the tensor tympani muscle. The mean length of this LPN is about 15 mm from geniculate ganglia to the foramen, where it exits from the middle cranial fossa. This lesser petrosal nerve goes floor of the middle cranial fossa anterior to the GSPN and passes medially in descent to reach the foramen ovale of the sphenoid bone, where it widely accepted to pass through together with V3 mandibular nerve, accessory meningeal artery, and emissary vein to the aortic ganglia, which is located medial to V3 just below this foramen, and from where it goes to the parotid gland by the auriculotympanic branches. In the infratemporal fossa, the LPN reaches the aortic ganglia, which hangs off the nerve of the tensor tympani. The preganglionic parasympathetic fiber synapses with the cell bodies of postganglionic parasympathetic fiber in the aortic ganglia, which is located medial side of the mandibular nerve V3. Around origin of the medial pterygoid nerve, the sympathetic fiber that joins the nerve from the middle meningeal artery passes right through the aortic ganglia. The postganglionic parasympathetic secretomotor fiber from the aortic ganglia passes to the parotid salivary gland through the auriculotemporal nerve originating from the B3, which lies in the contact with the deep surface of the gland. The Arnold's nerve arises from superior ganglia of the vagus nerve. It joins the some filament of the glossopharyngeal nerve and passes behind the internal jugular vein and enters the mastoid canaliculus on the lateral wall of the jugular fossa. Traversing the substance of temporal bone, it crosses the facial canal about 4 mm above the stylomastoid foramen, and here it gives off ascending branch which join the facial nerve. The nerve reaches the surface by passing through the tympanomastoid fissure between the mastoid process and tympanic part of the temporal bone, and here it gives two branches, posterior auricular branch and other, which contribute to the skin of the ear canal. So this Arnold nerve enters through the mastoid canaliculus into the middle ear. Clinical significance of this Arnold's nerve or Elderman's nerve is: first is it may involve a glomus jugulare tumor. Sometimes laryngeal cancer can present with pain beyond the ear, and this is called referred pain through the vagus nerve to the nerve of the Arnold. And some patient may present with the ear cuff reflex or Arnold's reflex. Physical stimulation of external auditory meatus innervated by auricular nerve elicit a cuff, much like the other cuff reflexes associated with vagus nerve. So rarely, on introduction of speculum or external auditory canal stimulation, patient can experience syncope due to the stimulation of auricular branch of the vagus nerve. Some fiber of this Arnold's nerve join the middle ear branches of the tympanic plexus, which form the lesser pituitary nerve, which exit from the innominate canaliculus from the middle ear. Nervous intermediate part of the facial nerve exits the brainstem at the boundary between the pons and inferior cerebellar peduncle. It goes along the motor route of the facial nerve at the lateral end of the internal auditory meatus, where it joins this main route of the motor route of the facial nerve at the lateral end of the internal auditory meatus. Today's topic about tympanic membrane. Tympanic membrane is a semi-transparent. You can see this picture. It is not completely transparent. It is semi-transparent partition between the external auditory meatus and tympanic cavity, or you can say middle ear. It is in oval shape, about 10 mm tall, 9 mm wide, and 0.1 mm thick. So thickness is very less, 0.1 mm. It is placed at angulation of about 45 degree to the floor of external auditory canal. It consists of three layers: outer cuticle layer, that is stratified squamous epithelium developed from ectoderm; middle fibrous layer developed from mesoderm; and inner mucosal layer that is developed from the endoderm. And inner mucosal layer is low columnar epithelial layer. The color of normal tympanic membrane is pearly gray or pearly white in color. So there are two parts of normal tympanic membrane, is pars tensa and pars flaccida. Pars tensa is larger part and its periphery thickened and form a cartilaginous ring. That cartilaginous ring is called annular tympanicum. That fits in the bony sulcus, that is called tympanic sulcus, which is formed by the tympanic bone mainly, and that is bony, and it's above deficient, and deficient part of this bony sulcus is called notch of Rabinus, which having the another part of tympanic membrane, that is pars flaccida. And this pars flaccida between the anterior and posterior malleolar ligament is also called Sharpnell's membrane, that is Sharpnell membrane, and it is small triangular in shape. This part, pars flaccida, is triangular shape and it is between the anterior and posterior malleolar fold. It is thin because it doesn't have any fibrous layer. So this part deficient of the fibrous layer of the tympanic membrane. The fibrous layer of pars tensa having three type of fibers. The most lateral fiber toward the external auditory canal are radial fibers, which radiate from the umbo toward the periphery. So in this fibrous layer, most lateral fibers are radial fibers. Another fiber just inside to the radial fibers is circular fiber of fibrous layer. In between intermingled fibers are parabolic fibers. So these fibers are made up of collagen bundles. So outermost fiber in fibrous layer is radial fiber, then circular fiber, then in between intermingled fiber are parabolic fibers. So there are three types of fiber in middle layer, fibrous layer of tympanic membrane. You can see in this picture the layer of outer layer, that is cuticular layer, then followed by fibrous layer, and inner mucosal layer is low columnar epithelium in the section or histology of this tympanic membrane. So tympanic membrane having two surfaces, lateral surface and medial surface. As you can see in this picture, the lateral surface is concave towards external auditory meatus. It divided into four quadrants by the two imaginary lines. First imaginary line passing through handle of malleus and another line passing through the tip of the handle of malleus, or you can say umbo, at the right angle to the perpendicular line of handle of malleus. So there are four quadrants. Anterior inferior quadrant, you can see cone of light is there. Antero superior quadrant, posterior superior quadrant, and posterior inferior quadrant. So cholesteatoma is most commonly occurred because of retraction in the posterior superior quadrant. The medial surface of tympanic membrane is convex and maximum point of convexity is called umbo. Umbo is the attachment of handle of malleus on the tip of tympanic membrane where maximum convexity is towards the middle ear cavity. You can say tympanic membrane. The cauda tympani, you can see in this picture, is closely related to upper part of tympanic membrane, that is pars flaccida. Nerve runs from posterior to anterior aspect, medial to the neck of the malleus, close to the tympanic membrane. The relationship of tympanic membrane. Laterally, it is external auditory canal. Medially, there is tympanic cavity. Superiorly, you can see there is middle cranial fossa. Inferiorly, being jugular valve. And anteriorly, you can see there will be TM joint, and posteriorly there are mastoid cavity. So these are the relationship of the tympanic membrane. The nerve supply of tympanic membrane. Lateral surface supplied by two nerves. Anterior part is supplied by the auriculotemporal nerve, and posterior half of lateral surface supplied by vagus nerve, that is Arnold's nerve, and medial complete surface of medial is supplied by the Jacobson's nerve, that is a branch of the glossopharyngeal nerve. Now blood supply of tympanic membrane. There are three artery supply. You can see first is anterior tympanic artery going through petrotympanic fissure, and deep auricular artery going through scomotympanic fissure into the middle ear cavity and supplying the tympanic membrane. They are both artery. This anterior tympanic and deep auricular are branch of first segment of internal maxillary artery. Another artery which is supplying below is the stylomastoid artery, is branch of the posterior auricular artery. So overall tympanic membrane supplied by the mainly external carotid system, and venous drainage mainly in the external jugular vein laterally, and medially there is auditory plexus which is going into sigmoid sinus and transverse sinus.